We're very fortunate today to have Ray DeCiccio, Program Manager at the Fellowship Center, in order to provide our training for us. This training today is provided to you by a contract with the San Diego County Behavioral Health Services Agency and supports the Live Well San Diego initiative, which is a vision of a San Diego region that is building better health, living safely, and thriving. And now I'm going to go ahead and turn it over to our trainer, Ray.
Good afternoon. This is Ray DeCiccio, as Elisa said. Thank you so much, Elisa. I really appreciate the introduction. And I also appreciate everybody joining the webinar and the opportunity to be of service to our system here in San Diego County and all you beautiful people who provide the services. Today is an introduction to the ASAM criteria. There are more webinars planned, so today's overview hopefully will lead into more in-depth webinars later on. But by the end of this webinar, you will know, are you advancing them, Lisa? No. By the end of this webinar, you will know what the ASAM criteria is, or I hope you'll know, how using the criteria can improve assessment in our treatment system here in San Diego County, what the 6 dimensions we use for assessment are, and how the criteria risk rating system works, and finally, what are the levels of care defined by the ASAM. Then there'll be an opportunity for questions. Now, this is a lot of material, and all of the material for the presentation was taken from the book you see pictured on the slide. The book's title, official title, is The ASAM Criteria, Treatment Criteria for Addictive, Substance-Related, and Co-occurring Conditions. And I believe the webinar will be available for your review and for staff training at any time. Okay. So a big question is, how do we decide what type of treatment or services our clients or participants need? And I believe that we can all agree that we all have different answers to this question. Each program has its own history and culture and referral sources, gatekeeper culture, and as we move towards developing an organized system delivery of care, how we answer this question is becoming more and more important. So if you're working within an organized system of care, meaning the programs in the system work together, and there are different types of modalities of treatment, and everyone uses different methodology to assess and refer, obviously there would be confusion, chaos, maybe, and certainly inappropriate placement and certainly poor outcomes. So, and the reasons for the chaos would be because we all use different lenses to determine treatment. How many of you have heard, well, my probation officer said I need to do 6 months residential drug treatment or 6 months non-residential drug treatment? So, our programs, we see a lot of clients referred from families, from the legal system, from social services system, from the medical system, mental health system, and all of those folks have certain expectations from our drug treatment programs. And they expect that we'll accept whoever they're referring, and sometimes they expect that our services should resolve all of their clients' problems. In addition to those expectations, we have to deal with the flavor of the month treatment modalities and how and what treatment programs are being currently funded. And we all do the best that we can with what we are given, but often we're faced with clients in residential, inpatient, or outpatient settings, mainly because of the funding source, or because the treatment's available, or the court ordered it. And usually there's expectations that go along with that go far beyond substance abuse treatment. So, like changing their criminal behavior or improving their mental health problems. This is not ideal for us. It's stressful, it causes inefficiencies, and it impacts our outcomes. So adopting the ASAM criteria as an assessment tool for an organized system of care can make our jobs a little bit easier and improve the system. Anyway, that's the hope. So is the ASAM criteria another flavor of the month? I don't think so. The ASAM criteria has a long history, and as we move forward with transformation in our healthcare system, providing services to reduce substance abuse will become a key component of the healthcare system. The real transformation for our healthcare is related to providing more and better upfront services like prevention and early intervention to reduce downstream healthcare costs, especially those related to chronic disease. And one of the major causal factors in most costly chronic diseases is substance abuse. So the substance abuse system is an important part of the healthcare system, whether we know it or not, whether we like it or not. And it makes sense that we engage with that larger system using a common language. So ASAM has a long history, and it was started for placing patients with substance abuse issues. And a major emphasis, it's gone through a lot of revisions over the years, and a major emphasis of the latest revision is to provide a user-friendly guide to understanding the principles, processes, and procedures to implement and apply the ASAM criteria to a variety of populations, including those with co-occurring conditions, and in a wide range of settings. So as San Diego County moves forward using this tool, much of the training will refer to the text. I keep a copy nearby, and I realize that the more I refer to it, the more skillful I get. And you know, the county has developed a desk reference guide called a crosswalk that counselors will use, and we are in the process of developing a desk reference guide for counselors that will be a small guide people can put on their desk, use as a guide to using the ASAM, and it will include elements of that crosswalk in a way that you don't have to look at a big chart in order to use the crosswalk from using assessments like the ASI that you're used to, and walking them over to the ASAM. So there's going to be a lot of help in the future, both from the county and from other sources, from the state probably, to help with this ASAM criteria. And it's important that we understand, you know, what is the ASAM criteria used for. ASAM is a clinical guide, and it's used with your clinical judgment to make decisions. Intentionally using the clinical guide tool in synergy with clinical judgment builds skill in assessment and reassessment, and builds skill in placement and replacement. So clinical judgment is actually going to become more important as you use this ASAM. In the ASI, you're not asked to rate anything or evaluate anything, you're collecting data. And so using the ASAM will actually make you engage your clinical skills more than just using the ASI. So what is the purpose of the ASAM criteria? Using this tool, the ASAM criteria, in our clinical skills makes possible objective decisions about treatment and that are individualized. So we're looking at the person as an individual. We're making an objective decision about that person, and those decisions will be defensible. It also supports treatment of co-occurring conditions by giving us the language to provide in-house treatment or to make referrals to medical or mental health conditions that are barriers to treatment success, and to work with those providers to integrate services. So this could be a very powerful tool for us. And what are the advantages? Well, words are magic. Language has been at the center of all human development. As language has become more specific and universal, science and technology have advanced. So too in our field. As integration with mental health and primary health care moves forward, we find that having common language helps when our clients need services from other parts of the system. So as language progresses, the science progresses, and our effectiveness and outcomes progress. So the substance abuse treatment system has gone through a lot of changes over the years. Initially, it started out just treating the symptoms. So if you were drunk and fell down and broke your arm, you went to the hospital, they fixed your arm. That was it. Then we started developing programs like 28-day programs or 90-day programs. Some of them were social models. Some of them were other types of models. But the program was the program, and the people either did well in the program or they were referred to another program. As treatment has progressed, we are building a client-directed, outcome-informed treatment system. This has a lot of advantages for us because we're not only just collecting data from biopsychosocial dimensions, but we're adding an evaluative component to that. And when we discover problems and priorities, we're building engagement and alliance, working with multidimensional obstacles that inhibit the client from getting what they want. So not only are we doing assessment, but we're identifying the problems that get in the way of what the client wants. And we build this therapeutic alliance, and the therapeutic alliance is the greatest determinant of outcome for treatment. So how well your counselors, other treatment providers engage with the client is the largest determinant about the success of your program. And so in this new model, we can right away determine what is the client there for. We can agree on goals and strategies and methods and build a collaborative treatment contract. And also work with the client's strengths in each dimension, which is very important. And we can make a treatment plan or a plan and treat with a broad, flexible array of services, and clients can move fluidly between them. The client can enter the system at any level and move as needed. Clients don't have to fall at a level of care to move up or down, or fail at a level of care to move up or down. So they don't have to fail at non-residential treatment in order to get into a residential treatment. Go with the least intensive services that are safe and secure for the client. So if you have a limited number of services or levels of care in your agency or in the region, linking with other providers is needed, and this system gives us that ability. Lengths of stay are not fixed, but depend on the severity of the illness and the progress or response to the treatment that's provided. So progress is always measured. Every session, every outcome in the therapeutic alliance is measured. We work to prevent dropouts and use the session rating scales and outcome rating scales in our system. So this helps us use motivational interviewing and relapse prevention, which are the evidence-based practices that San Diego County has determined they will use if and when we engage in the 1115 waiver. This is my favorite slide here. So the heart of client-directed treatment, and the heart is the right word here because using the biopsychosocial assessment to better engage the client requires the use of respect, empathy, genuineness, and warmth. Traits that make the use of motivational interviewing and relapse prevention strategies more effective. by developing collaborative goals, strategies, and methods. So engagement is critical, and when clients are engaged, the science shows they are more likely to improve in every aspect of their recovery and their life. So when you read a list of advantages of using a multidimensional assessment like the ASAM to achieve client-directed care, we use a multidimensional assessment to achieve client-directed care. It points to how the ASAM criteria can help San Diego County develop an organized system of care with multiple levels and flexible services. So those were big words. What is multidimensional assessment and biopsychosocial severity and function? In the ASAM, there's an assessment and treatment planning focus for each of 6 dimensions, which you see on the slide there. I call them ABERRR. Acute intoxication and/or withdrawal potential, biomedical conditions and complications, emotional behavior, cognitive conditions and complications, and then the 3 R's, readiness to change, relapse or continued use, and recovery environment. I'll cover those 6 dimensions quickly and then go into more in depth with them. But in dimension 1 allows us to assess for intoxication and/or withdrawal management, to ensure safe detoxification and withdrawal management in a variety of levels of care. So there will be a variety of levels of withdrawal management that we can refer people to, and we want to be able to assess what level to refer them to and prepare. And it also gives us an opportunity to prepare for continued addiction services using motivational enhancement techniques. So this first dimension is important. Dimension 2, assess and treat co-occurring physical health conditions or complications. And we assess those to ensure treatment for physical health problems is provided within the level of care or through coordination with physical health services from local providers. I mean, we could employ visiting doctors or telehealth or lots of creative ways of dealing with the problems in this dimension. But first we have to assess them. Assess and treat co-occurring diagnostic. Dimension 3 is assess and treat co-occurring diagnostic or subdiagnostic mental health conditions or complications. This is to ensure appropriate mental health treatment is provided within the level of care or through coordination of mental health services in the community. Dimension 4 is to assess the stage of readiness to change, determine the stage of change to engage treatment and to accomplish the tasks associated with that stage of change and using motivational enhancement strategies to move forward. I'll talk about that a little bit later. Dimension 5 is assess risk for relapse and readiness for relapse prevention services. To apply strategies from the relapse prevention model, which is an evidence-based practice for treatment, where appropriate. If still at an early stage of change, focus on raising consciousness or consequences of continued use or problems with motivational enhancements, or continued use or problems by using motivational enhancement strategies. That's in Dimension 5. Dimension 6, assess the recovery environment to determine the need for recovery services, including relationships, family, housing, financial, vocational, educational, legal, transportation, and provide assistance including motivated referrals and directed services through coaching or case management. Also an important dimension, and takes us even past the treatment services and out into community. So a little bit more about Dimension 1. What are we trying to evaluate or assess here? We're trying to, what risk is associated with their current level of intoxication? Do we need to take their keys from them? Are they a danger to themselves? Are intoxication management services needed to prevent drunk driving or overdosing? Is there significant risk of severe withdrawal symptoms, like seizures, based on withdrawal history and recent use patterns? So you can see some of these things, most of these things, if not all, we already do in the ASI, and we have done for years. So it's not that we're assessing new things. We're going to assess what are the current signs of withdrawal. What are the vital signs? Does the patient have sufficient supports to assist in ambulatory withdrawal management? That's medically safe to consider. So, we're going to try to avoid potential hazards and consequences of withdrawal. We're going to engage and facilitate the patient to complete withdrawal management and link to services. And then we're going to promote patient dignity and ease discomfort. Those are the things that we'll be assessing for in the first dimension. You've seen these guys in your treatment programs a lot, Dimension 2 is about assessing biomedical conditions and complications. So the assessment considerations include, are there current physical illnesses other than withdrawal that need to be addressed due to their risk or potential for treatment complications? Like, will they miss required groups, or will they miss other things that are required in the program because they'll be at the doctor's or in the hospital? Those are all important assessments to make. Are there chronic conditions that need stabilization or ongoing disease management? Example would be chronic pain needing management, diabetes needing insulin. We know that diabetes is increasing all the time, so we're going to see more and more people with health problems in our programs, and it's important that we assess them at even more evaluative levels than we have been. So is there a communicable disease present that could impact the well-being of patients or staff? Especially with, MRSA now, there's a lot of people in our programs with MRSA, flu, TB, even scabies, bed bugs. We really need to do the best that we can to assess for those kinds of health problems. Is the person pregnant? What is her pregnancy history? What, if any, use of drugs during pregnancy has she had? So those are all important questions that we're going to assess in the ASAM criteria in Dimension 2. Dimension 3, a very important dimension, emotional, behavioral, or cognitive conditions and complications. And assessments considerations are going to include, are there psychiatric illnesses or psychological, behavioral, emotional, or cognitive conditions that need stabilization or ongoing treatment? Sound familiar? I think we all try to do that now. Major depressive disorder or bipolar disorder or chronic anxiety are good examples. Are there chronic conditions that need stabilization or ongoing treatment, like depression? Do any emotional, behavioral, or cognitive signs or symptoms appear to be an expected part of the addictive disorder, or do they appear to be autonomous from the addictive disorder? It's always a question that we have that the ASAM criteria is going to help us determine. Are symptoms connected to addiction or not severe enough to warrant specific mental health treatment, like suicidal ideation, severe anxiety? Is the person able to manage activities of daily life? Can they handle the structure and requirements to be in a program? Also, it's important to note that there are spiritual aspects that need to be assessed, and that goes into Dimension 3, related to what gives meaning and purpose to an individual in their life, and what do they appreciate, what are they grateful for, what's their connection to a higher power, or do they believe in transcendence of any kind? Those are all important issues for Dimension 3. Dimension 3 is so important that they've provided us with 5 different subdomains in Dimension 3 where we can further assess risk and give ratings to. The 5 subdomains will help us determine the level and give us a picture of the person's co-occurring disorders. So that's Dimension 3 is a very important part of the assessment, and the ASAM gives us a little bit better picture of the co-occurring disorders, and the way it's used will give us a better conversation of how to talk to the client about their co-occurring disorders and how to refer them and what other services might be helpful. So moving on to Dimension 4, we've all had training in, maybe not all of us, but many of us have had training in the trans-theoretical model of change, which states that everybody who is successful in changes goes through certain stages of change: pre-contemplation, contemplation, preparation, action, and maintenance. And that there are certain tasks that need to be accomplished in each one of those stages of change, and that there are certain strategies that can help people accomplish those tasks. And therefore, it's important for us to be aware of the stage of change that they're in and be able to assess that. So assessment considerations include how aware is the person of the relationship between his or her alcohol, tobacco, or other drug use or behavior involved in the pursuit of reward or relief, like gambling or some other addictions. How aware are they of the relationship between that and the negative life consequences that they may experience, or negative health consequences, or negative legal consequences? How ready, willing, or able does the person feel to make changes to his or her substance use or addictive behavior? So we're going to be able to assess how ready or how willing or how able they are. How much does the patient feel in control of his or her treatment service? So all the science indicates that people who accomplish the tasks of each one of these stages are more likely to be successful in making lifestyle change and to maintain those changes over time. Dimension 5, relapse, continued use, or continued problem potential. The assessment considerations in Dimension 5 include: is the person in immediate danger of continued severe mental health distress and or alcohol, tobacco, and other drug use? So we're assessing for immediate danger of continued severe mental health and distress and or alcohol, tobacco, and other drug use. Does the person have any recognition or understanding of or skill in coping with his or her addictive behavior or co-occurring mental health disorder? Have addiction and or psychotropic medications assisted in recovery before? So we can find out what's worked before. What are the person's skills and strengths in coping with protracted withdrawal, cravings, or impulses? We're going to go into finding out their skills and strengths. How well is he or she able to cope with negative affects, with peer pressure, or with stress? Find out what their skills are and strengths are with those issues. How severe are the likely problems and distress if he or she continues to use or have mental health difficulties? How aware is the person of relapse triggers and the skills to control harmful impulses? So, a lot of us have learned about post-acute withdrawal symptoms, and we're actually assessing for a lot of that and then much more. So this is an important assessment to make, especially since relapse prevention is one of the evidence-based practices that we'll be using in San Diego County. So when I talk about assessing, we're assessing for risk. And the reason we're assessing for risk is to place the patient in the proper level of service, and then to do a treatment plan that's individualized, that's patient-centered, patient-oriented. And in order to do that in the most powerful way, we have to put a rating on the risk. So in each dimension, we need to determine a risk rating, which forces us to use our clinical skills in the assessment and puts an evaluative methodology with metrics in our hands to use in many powerful ways. So what is a risk rating? And ratings usually have levels, and here in the ASAM, we rate it from 0 to 4. And establishing a risk rating system creates a standard methodology for assessing severity and level of function for each of the 6 ASAM dimensions. So helping to identify individual priorities and needs is important. Ratings also brings the system closer to consensus, minimizes confusion about assessment of clients, especially those with co-occurring disorders. So an individual's severity and level of function is termed risk. And the risk rating in each dimension and factors related to dimensional interactions are major determining factors in placing patients in appropriate settings and modalities. So once again, an individual's severity and level of function is termed risk. And how we rate that in each of the dimensions are major determining factors in placing the patient in service, appropriate service, setting modality. It's also important in determining treatment plan and reassessing for placement all the way through treatment. However, to optimize the use of treatment and financial resources, care must be strength-based. So this ASAM criteria really flows well with strength-based methodologies. By strength-based, we mean that looking for what the individual's skills and strengths are, what their goals are, and to work to help them achieve those. So while the 6 dimensions are assessed for needs and barriers to recovery, they also structure the assessment in a way that a person's strengths and skills and resources are brought out. It helps to explore these issues by using appreciative inquiry or positive questioning, as they call it, exploring periods of success and how they've coped with those, what coping mechanisms they use and how they coped with those problems in the past, how they managed them. And that's really going to be an important addition to our assessment that's not really even touched on in the ASI. So when all rating systems, when you're assessing for or evaluating, there's principles. And because the risks that we're looking at are multidimensional, each of the 6 dimensions is assessed independently and receives its own risk rating. The risk can be mediated by protective factors, and addressing a patient's risk may require more than one treatment component. So if you have someone that has medical problems as well as psychological issues and addiction issues, we may need more than one component. And we can also identify what are the strengths that those clients have that we can use to help them deal with those issues. So a patient who experiences seizure and withdrawal has a different needs than one who doesn't. So The patient's history also encompasses success so as to identify strengths and skills and resources that can be harnessed in treatment. A person has an elevated vital signs in response to discontinued alcohol use requires different treatment services from a calm person who is not currently drinking. Current factors also include protective factors such as stable living situations, supportive family, etc. So the degree of a changed person who was previously fully functioned and suddenly withdraws from social contact needs intensive services, whereas someone who is chronically withdrawn may not. So someone who's been active and engaged socially and then all of a sudden becomes withdrawn, we can tease that out in this assessment, and we can understand that that change in behavior actually puts them at higher risk than someone who's withdrawn in the normal course of life. The intricacies of risk rating will really help us in developing a better idea of our clients, not only with the problems and barriers that they face, but also with the strengths and skills that they have. So when assessing an individual's risk potential, risk assessments are evaluated for each of the 6 dimensions. And dimension 1 and 2 only apply to substance abuse issues and medical complications accordingly. So in intoxication and in dimension 2, we're really looking at how do what we observe, what we're evaluating here, how do they relate to substance abuse. Dimension 3, it uses risk domains to assess risk. And in dimension 4, 5, 6, address risk ratings for both substance abuse and mental health. So in dimension 3, we're really dealing with mental health and cognitive behavioral issues. Dimension 4, 5, and 6, it's both substance abuse and mental health issues. So these are little tricks that we can build on as we provide more training and more in-depth practice in using the ASAM. So we're evaluating and rating assessing in each one of 6 dimensions in order to do something. And one of the things that we're trying to determine is what level of service does best matches the client that we're assessing right now. So the ASAM criteria describes treatment as a continuum marked by 4 broad levels of service and an early intervention level. It uses innovative overlap to create a seamless continuum of flexible services and levels of care. Access to care and efficiency and effectiveness of services can be greatly improved. We have 4 levels of care, and there's intricate levels in between in order to make it seamless. For example, the ASAM describes a continuum to 5 levels of withdrawal management. I'll show you on the next slide, but instead of having one way of detoxing people, you put them in a 10-day detox, even if they've relapsed and they've used twice. And we've assessed that they don't really have a lot of withdrawal management potential, but the way the current system was set up, they went to 10-day detox anyway, or 5-day detox, or whatever the program was set up for. Under the ASAM criteria, there are 5 levels of detox. One is mild withdrawal with daily or less than daily outpatient supervision, likely to continue treatment or recovery. So a person who would assess into level 1 has mild withdrawal symptoms and is likely to continue in treatment or recovery. A person who would assess into level 2 withdrawal management system has moderate withdrawal and needs all-day support and supervision, but at night has supportive family or living situation, and they're likely to complete withdrawal management. Level 3.2 is clinically managed residential withdrawal. Means they're going through moderate withdrawal but need 24-hour support to complete withdrawal management and increased likelihood of continuing treatment or care. 3.7 is severe withdrawal and needs 24-hour nursing care and physician visits as necessary. Unlikely to complete withdrawal management without medical, nursing, or nursing monitoring. And of course, number 4 is severe unstable withdrawal and needs 24-hour nursing care, daily physician visits to modify withdrawal management regimen and manage medical instability. So those are, it's an example of 5 levels of withdrawal. Number 0.05, which is an early intervention, is for those individuals who are at high risk for developing substance use disorders or for whom there is insufficient information to document a substance disorder. You know, I know that SAMHSA is moving across the country saying that 90% of people who could benefit from substance abuse services never receive one service in their lifetime. And this is one of the areas in which the ASAM criteria can help us be more effective in providing substance abuse services and being a more integral and important part of the healthcare system by providing these upfront services for individuals who are at high risk for developing substance abuse. Examples include like screening and brief intervention, referral to treatment, UI education, basic AOD education, early intervention with adults. And who could be better than that than counselors? AOD counselors have been trained. Even recovery coaching and telehealth. These are all modalities of service that open up to us with this ASAM criteria. So level 1 of treatment is outpatient services. And any level of outpatient services may be addiction-only services, or they may be dual diagnosed capable, or dual diagnosed enhanced. So whether it's intensive outpatient or outpatient treatment, all 3 of those can be included. Addiction-only, dual diagnosed capable, or dual diagnosed enhanced. A dual diagnosed capable program has the primary target population of individuals with substance abuse related disorders, but also have an expectation and willingness to treat individuals with co-occurring mental health conditions, in-house or referred to current mental health services available in the community. Dual diagnosed enhanced programs, the program has the combined capacity to treat both mental health substances and related disorders, mental health and substance abuse service related disorders equally. So level 2 is intensive outpatient services. And intensive outpatient services provide treatment during the day, after work or school in the evening. And they provide 9 or more hours of services. They have the capacity to provide medical and psychiatric consultation, pharmacological consultation, medication management, and crisis services. So 2.1 is 9 or more hours of service, and 2.5 of intensive outpatient services is 20 or more hours of service per week. And that's usually for multidimensional instability, but it doesn't require 24-hour care. Level 3 is residential inpatient treatment. The Level 3 programs provide 24-hour treatment services in a safe environment, but there's 4 levels, 3.1, 3.3, 3.5, and 3.7. 3.1 is clinically managed low intensity, so it could be as little as 5 clinical hours per week, and could be, an example could be a shelter plus care program, or you know, a sober living facility that's providing 5 hours of clinical treatment, or a recovery home that's providing 5 hours of clinical treatment. 3.3 is clinically managed medium intensity, lower intensity milieu for cognitive or other impairments. 3.3 is programs for people who cannot, like if your treatment center requires going to groups every day, requires, like ours does, requires you be engaged in the treatment process and be a part of taking care of the property, taking care of your own space. That can be very, very stressful to do that all day long, going in and out of groups and you know, having to be in certain places at certain times. And if people are not able to participate in that, a 3.3 level program would provide individualized treatment but not require all of that intensity of the person. And so people with mental health issues that would keep them from participating are an example of a clinic who would benefit from a clinically managed program. 3.5 is a clinically managed high-intensity program, and these are usually community-based programs that provide 20 or more hours a week of clinical treatment, meaning groups or meetings with a counselor or house meetings or other you know, clinical interventions that help provide change processes, dealing with respect, responsibility, you know, dealing with the tasks of the stage of change, trying to accomplish the goals of the treatment plan, anything that's focused on that kind of treatment up towards those hours. Level 3.7 is a medically monitored inpatient program, would be like the typical Betty Ford program, type program where there's counselors, there's mental health professionals, and there's medical professionals available 24 hours a day. So the medically managed inpatient is, it has the capability, that's level 4, it has the capability of an acute care hospital or a psychiatric hospital right there. So if someone needs to go get tests or needs to go to critical care or intensive care, or they need rehabilitative services, the hospital is right there to provide those services. It's for severe unstable problems, and there, of course, they must be dual diagnosed enhanced. That's level 4 of treatment. So I went really fast over a great deal of material today, and there's a great deal we have to cover. And it's important to note that San Diego County has developed a crosswalk document that will help us identify the assessments that we use in, like the ASI and other assessments that we use, and how to crosswalk that into the dimensions of ASAM criteria. And we'll also be talking more in future webinars about how to determine the strengths and skills, and how the risk rating system relates to referrals and other kinds of services, and how we actually specifically develop those risk rating systems or risk ratings in each one of those dimensions in a way that's fairly consistent across the county, at least that we're using the same language, we're using the same types of assessment, we're becoming closer together in how we rate certain risks by the questions that we ask. The questions that we'll be talking about in the next webinar are how to use the risk rating system in each dimension, matrix matching, where we're talking about level of function and how that fits in with the types or intensity of services, and how to use what we learned from our ASAM criteria in service planning and placement. We'll talk a little more about withdrawal management and how to use the ASAM criteria to identify people who would best benefit from a level of withdrawal management and other related topics. So, I said it's really important to me to be of service around this, and so any questions, suggestions, feedback, I may not be able to answer all the questions, but I have a pen here, and I will make it a point to find the answers and get them to you. And I know this is complicated stuff, so I wanted to ask some questions about what's easy for you, what would work better, and those kinds of questions. Okay. So I'm going to go to some of the questions here. Oh, it looks like you guys didn't have sound for a while. I didn't even know that.
So for those of you that have questions right now, if you want to go ahead and type them into the chat feature right there, that way Ray can see them and he'll have a moment here to answer those questions.
Okay, so how can I receive CEUs for this course? I'm not sure, but I'm going to find out for you. When will the recorded version of this be available? Lisa, can you tell me that? Or I think it'll be available
for the CEUs, for both the recorded version and for this live version. Those will be available through our website. And then the recorded version will be available as an e-learning in probably about a month or so.
So what was easy to grasp, what was not so easy to grasp? Here's a question from Jeremiah. Hi, Jeremiah. Would you advise someone who is using and getting mental health services such as therapy? Advise someone. Do you recommend that they go to rehab first and then address counseling at the clinic? This is one of the things that using the ASAM criteria will be helpful, because when we go into dimension 3 and start asking the questions and putting them into the criteria, we get a better idea of whether the mental health issue came first or was a result of the substance abuse. And then you can use your clinical judgment and actually get feedback from supervisors and others, talk among your peers to to see exactly what treatment will be helpful for this person, and when should we provide them with a mental health assessment or provide mental health services. One of the things that providing the seamless system really is helpful for, because it doesn't really matter if you have a seamless system. If you accept them into a substance abuse treatment, then you have a lot of capacity to deal with mental health issues, depending on what the mental health issues are. I hope I've answered your question, Jeremiah. If not, back to it. Robert Cook, we should purchase ASAM Criteria. I highly recommend purchasing the book because they really tried to make it easy to use. It's not very easy to use, but after we are now in the process of publishing a small desk reference guide that will have aspects of the crosswalk in it, and we should be making the crosswalk available to you very soon. The county has the crosswalk. So between those three documents, if you use the desk reference and you run into a problem, you can always go over and pick up your book and look it up in the book and try to get some more clarification. So yeah, I would highly recommend purchasing the ASAM Criteria book, even though it is a little bit expensive. Will the ASAM, okay, so from Richard Henley, will the ASAM be administered by AOD counselors or by clinical staff such as LCSW, LMFT, or both? There's 90% chance that it'll be both. And at the Fellowship Center, we're already starting to train our counselors to use the ASAM criteria. We actually even ask in our group supervision, well, you know, how did you assess this person in all of the dimensions while you were doing the intake process or after you did the ASI? So that we're starting to get our counselors to practice using the ASAM, getting information into each dimension, and starting to think about, well, what does a risk rating look like, and what would a 4 look like, and what would a 3 look like? So, and I would imagine that the counselors are going to be using the ASAM criteria continually throughout the treatment process. So if 2 months down the road someone assesses differently in ASAM according to the dimensions, it may be time to refer them to a lower model of treatment or a higher level of treatment. So we'll constantly be assessing using the ASAM. And I know up in Santa Clara County, where they've been using the ASAM for a while, you go there and everybody's talking about ASAM, the counselors, the county staff. They're constantly assessing and talking about why they rated this person a 3 or this person a 4 in this particular dimension. So I think the ASAM criteria will be a key factor in the organized delivery system of care that's developed here in San Diego County, and not only counselors and clinical staff will be using it, but maybe even the medical doctors. So, okay, another question from Richard. It seems that if licensed mental health staff are going to administer the ASAM, it would be highly beneficial that they also have AOD treatment experience. But, well, my thoughts are it would be highly beneficial for doctors also, and licensed mental health staff to have AOD treatment experience. I think it's probably impossible to fill positions with people who have that experience right away, but we really have to focus training and developing our staff, whether it's clinical staff or counseling staff or medical staff, and particularly using motivational enhancement techniques and how that relates to AOD treatment. In my opinion, the janitors should be trained in motivational interviewing. The cooks should be trained in motivational interviewing. In our program, we train our resident counsel in motivational interviewing so that they know what an open-ended question is, what respect means, and how to engage another resident in a way that is respectful and responsible and allows them, the new resident, a chance to hear whatever the issue is without feeling judged or criticized. So I believe everybody should get that kind of training.
I'd like to thank everyone for joining us today. This is the end of the webinar, and we appreciate your being here. If we could ask everyone to please take just a moment and click on the link that's visible there on the PowerPoint and take the brief evaluation survey and give us your feedback on today's webinar. We would really appreciate it. Thank you again for joining us, and we hope that you have a great day.